I am Pam Fleury, and I run the product management team for healthcare here at Oracle. And I have been in healthcare for over 25 years, and so I'm really looking forward to having discussion about FHIR and all of the components regarding the connectivity and interoperability that follows. In my background, everything you do in revenue cycle and the clinical world has to do with connecting to downstream systems. So to me, this is a pretty important topic.
Hi, I'm Glenn Lottering. I head up our Oracle Health Insurance Solution Engineering globally. Been in the industry for more than 30 years. And I'm very excited about the topic that we're going to share with you today. Pam and I work hand in hand within our two divisions to solve for health payers problems in this particular area. And it leads to a very interesting discussion, particularly because there is some regulation that is driving some of the requirements that we're going to talk about today. Pam, if I may, could I ask you to maybe just introduce the topic for us today? And as you and I go into this conversation, I'm sure we're going to be able to just to and fro in the conversation about interoperability.
So with the update to the Cures Act, there was an update made last year that finalized within the United States some key areas. So two of them, one covered the interoperability, so the ability to access specific sets of information and following a standard such as FHIR. And what that FHIR standard is basically the latest version of FHIR. The other side of that act was the blocking of information. And so the two go hand in hand, which means that in the past, it was difficult for individuals to obtain specific sets of data here in the United States from a system perspective. And what we're doing is we're opening that up. And in conjunction with that, we are the rule by the ONC committee that was passed also identified the ability to not block information, which means everybody needs to have an attempt at ensuring that people have access to specific sets of information. And so it covers several areas. It covers the patient access area, it covers the provider area, as well as certain sets of data within the payer area.
So Pam, I think it would be good for us to do a level set and maybe just describe how we see the Cures Act and this interoperability regulation impact the industry. Could you run us through that and how you see the impact for the industry itself?
Yeah, I think the impact, because the Cures Act is really targeting access to health records, it's really also bringing us up to the late, the 21st century. So we are looking at how you can access that data through smartphones, through web services, making sure it's secure as well. So some of the examples would be, when here in the States, especially when a patient goes and sees their provider, some providers have a portal, they have access to view some of their records, but that's where it starts and ends. That information is not necessarily accessible to other devices as well as other areas within the healthcare ecosystem. So, for example, when a patient is traveling and say they're vacationing down at Disney World and they need to go to urgent care, and they go into the emergency room, and in the emergency room they have no idea if that patient has allergies. They don't know what the history is of that patient unless that patient informs them. So what the Cures Act does is, and the lack of blocking of information, what that does is, if there is the ability and the intent of transferring that data from what that patient's primary care physician has to where they are located in Florida and emergency care there, having that ability to share their data so that clinician is well informed and has a good way of developing a care plan to support and treat that patient.
Mm-hmm. Are there any particular dates associated to the Cures Act that is of importance?
Yeah, so a lot of the dates were were updated or modified due to COVID. So some of the APIs that were specific to the patient access, the provider, as well as the payer-to-payer, they were supposed to be in effect as of January of this year. They moved to July as well as March of 2022. And what that means is they have the ability to start testing and start ensuring that they are not blocking that information from others to access.
Now, obviously, we're going to see some pros and cons in this. If we have a discussion with many of the payers in the market, we're certainly starting to hear how they would want to test out and try and understand how to make the data available. What do you see some of the pros of doing this?
So some of the pros are, I think, if you think of it from a patient's perspective, oftentimes the patient goes and sees a provider. The provider prescribes a certain therapy or a certain drug, and the patient thinks that it's, this is what I need to do to be healthy. However, if they're insured, specific insurance companies, of course, they have different rates that are negotiated, based on their HMO that they've signed up for. They don't really know what that cost is going to be for them. So the idea that transparency of cost for that patient's care and their next steps in their care plan is supposed to be more transparent. So I think that will help both the patient and the clinician make better informed choices as to how to move forward and not let cost or lack of access to something prevent them from receiving that care.
Yeah, which is at the core of the health industry, right? So making good care available at affordable prices to all in the ecosystem. Talking through that particular point, and we look at how care is made available to individuals across the board, do you think that we're going to see a movement more towards the patient being in the driving seat and they could actually, make their own decisions? Or are we still going to see that payers and providers through their agreements will drive the conversation?
So it's a great question, especially in the United States, in a domestic market here. That consumer, I think, is going to start driving the market more, especially with COVID. COVID really highlighted the need for patients to go and, perform their own health checks, identify what their O2 rate is, and really taking their initiative, meaning having access and doing research. And I do think that the consumers are going to drive where they're going to have their health care provided and how it's going to be provided. So I think it's sort of a two-pronged approach. Consumers, and it's all generational. Both the younger generation as well as the elderly generation. What COVID really did was sort of highlight the ability to have that access through whatever means, and not have to support that traditional care. So today, the consumer is going to be able to have the ability to not just shop around and find the best price, but identify what kinds of care that best suits their needs. If they don't want to go to a facility physically, if they want to have sort of a hybrid approach, as well as how that care is provided and by whom, will be not just a cost consideration, will also be the type of care that they will receive and the type of path going forward.
So this sounds like a really good situation for, the general consumer or member in these health plans. And quite exciting. I think that you're probably going to find that many of the consumers, once they become aware of this, will be quite excited about the opportunity. But what are the challenges facing the healthcare payers and providers around providing this patient data?
So the challenges are specifically the way the healthcare system's been in place to date. So generally, when a patient goes to a provider for care, they have a certain type of insurance. And so if it's a commercial insurance versus a Medicaid or a Medicare, only those companies have data, access to that data for that patient at that point in time. If that patient changes healthcare plans or adds a healthcare plan, that access or understanding of what's actually happening with that patient is no longer shared across the payers. So from that perspective, what that will do is it'll help the payers collaborate with providers to figure out the best way to keep that patient healthy, because they'll have a full longitudinal picture of what that patient's health is like, what kind of care is available to them, and better figure out financially as well as from a healthcare perspective how best to provide that, which then also translates to ensuring that all the providers that provide the care and in different types of care are also known and made available. So we're not just narrowing down to a subset of particular providers that may be in network, but really identifying what's the best thing for the patient and what's the most cost effective for that patient as well as for that payer.
So what it sounds like is my health history will move with me as a person rather than stay with a payer or provider. Is that what you're describing here?
Yeah, the health industry will move with the patient. And so as that patient goes through their, different avenues of their life, they may have different payers. What that does is they'll be able to share that health information with the payer as they move forward. So that payer will have a better picture of what that patient's life cycle is like, and be able to really better partner with that individual. There is some concern that this will be more of a cost preventative approach, but really what it does is it opens the doors to provide the best possible care, the best price, and making sure that both sides have a full picture of that patient. So it's not just a narrow view. It really opens up the door for the holistic view of that patient and the holistic view of how best to approach that patient.
Certainly sounds like we'll be able to move to a better picture of preventative care as well. So the IT challenges in this regulation being moved forward in this way is really going to fast track us to move to a real-time, interoperability model. And what we hear from the analysts like Gartner and IDC is that this is going to be front and center for payers to actually address as well as providers. Within Oracle, I think there is a lot of capability to address this. What would you think is some of the key assets that Oracle can bring to bear to address the particular IT challenges?
So I think the key in general, the IT challenges in general within healthcare, is that all the systems have been grown, right? And some of them are very old, and then they're taking newer technology and trying to layer it on. And the key in healthcare is I have different systems with different sets of data, and they also integrate or communicate with each other differently. So some are point to point, some are using HL7, and some are what the Cures Act does, and the standard they've chosen is FHIR. So with version 4, and what that is really an API-based solution. And by standardizing the communication mechanism across systems, what that really allows is open up the doors for solutions to communicate with one another without having to build point-to-point interfaces, creating a large cost for organizations that have those systems in place and enhancing their ecosystems. And so from an Oracle perspective, Oracle does have a lot of technology. We are a technology company that supports the capabilities of FHIR, as well as has a breadth of experience with HL7. We've worked with inside as well as outside the United States with large countries that are the foundation for their public health records across the board. So I think Oracle also has the components that are part of the key points of an ecosystem. So the Oracle Health Insurance from the payer's perspective, we have the healthcare data repositories that support the HIEs, both in the United States as well as outside the United States. And so we can demonstrate scalability along with the master person's index. So that's really kind of key too, to managing that patient and ensuring that all the records from a longitudinal perspective are able to be reflective of that particular individual. And so having the key components from the foundation of what's needed to support these efforts, as well as the scalability, because these become very large, very fast, and having seamless tools to do that integration is going to be really key going forward, as well as inserting AI where it makes sense and having those models be trainable so that, again, it will help other applications and existing systems that may have a harder time meeting some of these regulations in the timeframes that are made available because of the technology they were built on and what's going to be required going forward.
Yeah, I've certainly seen how we in the Oracle Health Insurance business unit have moved forward to make sure that the interoperability standards are attached to the way that we can communicate through our APIs. And that, of course, is going to be all important. As we've seen this FHIR standard actually used in other industries or other countries, quite successfully. We've had some success of this already in Australia. We've done the same in the Netherlands. Now, obviously, we bring in this capability into the US market where the complexity is so much higher, and it is a standard that will now be enforced. But considering this, and looking at the next steps, what would you think we will be seeing from the health payers, particularly of the next 6 months in terms of activity? What should they be doing and thinking about if they're taking on this kind of challenge, and how would you see Oracle be able to help them?
So I think the challenges that the payers are they're picking up right now is the payer-to-payer access, right? So generally payers in the past have not necessarily shared data across the two. In addition to the provider directory having that capability to really, we have an NPI, National Provider Identifier. However, that doesn't necessarily always help in when you're developing your databases and doing your access, as well as the prior authorization, truly automating that. I mean, some of the major health initiatives that are out there today, you need an authorization. And an authorization, while there's standards in place, it takes time. There's faxing involved. Not all the systems use the EDI transaction sets that are available. And so really opening that up. So if I was a payer, I would be looking at how to ensure that I have the ability to ensure that I'm exposing my data sets through the APIs that are mandated today. Not just targeting those identified in the Cures Act, but for all the data sets. Because if you start thinking about really moving forward, especially the US, we're not a public health system, but understanding that we're going to need to be able to share data across various systems, it makes sense to take a look at not just those APIs that are being mandated as of this Cures Act and the ONC, but also looking across the board. So I think your priorities are going to be ensuring that you can do the prior authorization, ensuring you can support the provider directory and build that out, but also by doing that, getting yourself ready to meet the payer-to-payer and identifying how that really intersects with your solution and your offerings as a whole.
So it sounds like there's some back office requirements, but also, B2C requirement, which will, of course, require real-time interoperability and put some challenges on typical, legacy and batch-orientated systems. How do you see, the current legacy environments deal with this kind of problem?
So in the legacy environments, they're certainly going to need a layer on top. I mean, it takes a lot to build out a net new revenue cycle or a net new scheduling cycle or a net system or a net new clinical system. So I think what we want to do is leverage those technologies that Oracle offers that enable you to layer on top of your application so that you can send the data in the data sets you have, and allow a server to bring in that data, do the modifications as needed, and send that out. So now you're able to meet the needs while you're building out and putting together the APIs that are necessary to meet the standards that have been mandated.
So it sounds like Oracle's got the toolkit for interoperability and meeting the Cures Act. I certainly think that to address these requirements, now's the time to act. One has to at least have your plan together and understand what you need to do at this point in time. It's not going to be something that you can wait on. And you have to have the right capabilities within your ecosystem to move into this new Cures Act. Would you just maybe give me a summary before we close the call out?
Sure. So I think what you're going to want to do from a legacy system, and there are organizations, HL7's FHIR organization has multiple work groups out there that we're participating in and setting those standards. But I think what you want to do is, do an inventory of your existing systems, identify what has the capabilities to support the FHIR APIs, understand that it's not just going to be a technology change or update, but you're going to be looking at your entire workflow. Specifically, first you're going to do your patient access APIs, and you're going to look at your authorizations, and you're going to look at the payer, depending on what part of the ecosystem you reside in. And with that, you're going to, obviously we want to meet the initial requirements, but you're going to want to sort of open the door, because what this really does is it allows you to build innovation inside your organization so that you'll have the ability to bring in multiple types of applications as well as solutions that meet needs. So you're not dependent on a single solution. And what that does in your organization is build out innovation and allows you to solve complex problems pretty easily without being tied to a specific set of solutions within your organization. So I think, the key is to ensure you do your inventory, identify those APIs that are missing, identify what phase that you need to meet them in, as far as from the time frames that have been applied here from the rule sets, and then come to Oracle, come to organizations that have the technology that really will help you then focus on the business side. So there's two parts of it. There's the technology side that those needs need to be met, but take advantage of this to really enhance your operations as a whole by using the technology that's available.
Thanks for all the insights, Pam. I really enjoyed the conversation with you. We hope to join each other in another conversation in the near future.
Same here. It's been a pleasure, Glenn. Thank you very much.